is from the Department of Ophthalmology. The chief discussant of today's presentation is Dr. Anusha Ganguly Kapoor Madam, who is its consultant oculoplastic surgeon from LV Prasad Eye Institute, Tadigadapa. And the subject moderator is Dr. Rajan Prasad Sir, the HOD of Department of Ophthalmology. And the presenter is Dr. K. Vibha Chaudhary, second year postgraduate, Department of Ophthalmology. Sir, I would like to call HOD of Ophthalmology to introduce about our discussion.
Good afternoon, everybody, and welcome to this CPC of our Department of Ophthalmology. And today's chief discussant is Dr. Anusha Kapoor Ganguly, is a head of Oculoplasty Department and Facial Aesthetics in LV Prasad Institute, Tadigadapa. So when I spoke to her over phone, she readily accepted to come as chief discussant, and very thank you, madam. Thank you very much for accepting our invitation and coming over here and sparing your valuable time. She did her MD Ophthalmology from All India Institute of Medical Sciences, New Delhi. Later, she did DNB Ophthalmology, and she is also got FICO, a fellowship of higher recognition. And now she is presently heading the Department of Oculoplasty in LV Prasad Institute, Tadigadapa. So, with this brief introduction, I will conclude. Let us start the discussion.
We will tell about him. Okay. The thing is, recently you might have seen that the world is almost 7th icon in ophthalmology. 7th icon, okay? And he completed only LV Prasad Eye Institute or its surrounding things. They have completed 50,000 in the world, the corneal transplants. 50,000. There's no other, even in United States, nowhere. So when we returned in 78, he returned 85. At that time I told him, I thought shame on our country that we are looking for corneas from Ceylon to do corneoplastics. We have so many patients, so many population. How come small country Ceylon is giving us? Why we are not doing? So your job is to get and do the corneal transplants. That's what he started. I told him that when it came in papers and all. So he's 50%, no charges. Absolutely no charges. In all places. So 6 or 7 are there. Vizag, Orissa, some other. And there are a few things we will tell about the satellite small clinics. Okay. She's going to tell about it before discussing about it.
We forgot to tell the LV Prasad Eye Institute submitted the research projects for grants of Padmavati 1 crore. They are able to garner 2 grants, that is 2 crores for 3 successive years. One of which is stem cell harvesting for corneal fabrication walls, which is being probably completed by the end of next year. And that foundation is none other than the foundation instituted by Dr. Nasir Agaru and Dr. Shura. Padmavati Research Grants Foundation, first time in the private sector for an outstanding project in which the entire India, there are hundreds of projects will be coming from the IMEs, IITs, MBAs, and then other molecular biology and IAS and all, 150 to 100. They screen to 10 and 1 will be selected. The selected candidate will get 1 crore consecutively for 3 long years. The patent should be submitted to them as well as to India. This is the first of its kind in a private sector, such a huge amount of $1.5 million. I hope one of these youngsters to rise that occasion to garner it from this institute in the coming decade. That is a cherished ambition. Hopefully, successful fulfilling. Any branch, fundamental research, back to the bedside.
A 26-year-old male patient was referred to our ophthalmology OPD from the Department of General Medicine, where he was diagnosed as a case of acute pancreatitis with complaints of drooping of upper eyelids in both eyes for the past 10 years, difficulty in night vision in both eyes for the past 10 years, and diminution of vision during the day in both eyes for the past 2 years. Patient was apparently asymptomatic 10 years ago when he noticed difficulty in night vision in both eyes. He also noticed drooping of both upper eyelids around the same time, which was gradually progressive. There was no diurnal variation and no improvement with rest. He also noticed diminution of vision during the day in both eyes for the past 2 years, which was painless and gradually progressive. There was no history of any pain and double vision, no history of any ocular trauma or head injury, no history of any food or drug allergies, and no history of any ocular surgeries. Personal history: mixed diet, normal bowel and bladder habits, normal sleep and appetite, not an alcoholic or smoker.
Bad voice. Good afternoon, everyone. So they want me to join Viva and help her dissect the case a little more. So I think till now, whatever you have presented, it's a very interesting case. So let us go back to the history. So what Viva has told out us till now, that it's a 26-year-old boy, and can you just highlight the important points in the history you have talked about till now? Yeah, age is 26-year-old. The history of acute pancreatitis, which is also very important in this case. The drooping of the upper eyelids, both the eyes, since past 10 years, that is around 16 years of age, the patient developed this, and you also said that it is gradually progressive. Anything else? Difficulty in night vision, again something I want to draw your attention to. Again, since the past 10 years, and decreased vision. Move on, Viva. No history of trauma. So why do you feel, Viva, the history of trauma is important in the case of ptosis? Why is this negative history important?
When trauma causes any mechanical ptosis.
Does it cause mechanical ptosis? You're correct that trauma causes a type of ptosis. Which is the type? So it can cause damage to the aponeurosis, levator aponeurosis, and cause a aponeurotic type of ptosis. So traumatic ptosis is a majorly aponeurotic type. So basically you are trying to rule out in your history part. So no history of ocular trauma or head injury. Very important. What else? Move on. So till now we have understood a 26-year-old, we have understood that there is bilateral ptosis. We have also understood that there is a history of acute pancreatitis. Move on, Viva. So Viva has also told us a very important history, that the patient had undergone a permanent pacemaker for a complete heart block, and also there is a history of hearing loss. There are no other comorbidities she has talked about. Go on, Viva. Family history is normal contributory, personal history normal.
As a specialist of ophthalmology at this point of time, because history is the most crucial component which can diagnose 85% of all remedies, the entire branches of all medicine branches, including ophthalmology. Therefore, you to focus at that point of time from history. What are the components which make you to nearer to the
correct
diagnostic possibilities at this point of time?
Because all these, these can't be just rare, coincidence that all of these are there in this patient. So with this history, with this age, 10 years age of onset, gradually progressive, pancreatitis, heart blocks, this can only be a particular syndrome which we very rarely do come across in our practice, which is known as Kearns-Sayre syndrome. So we will have to further, that is something we will keep at the back of our mind. And now we will go ahead, because the night blindness is again something which is pushing us towards the diagnosis of retinitis pigmentosa needs to be ruled out, which is again in the conglomeration of features of Kearns-Sayre. The other types of acquired ptosis like aponeurotic ptosis, chromatic ptosis, or mechanical ptosis, neurogenic ptosis, they are down in our differentials. Myopathic is the topmost differential. Congenital is furthest down because the onset is 16 years of age, which is not likely in a case of congenital ptosis. So with that, we will now move on. In the differentials, we have put myopathic as number 1 and the others we have kept down. So with that, should we move ahead with the general examination, and then again?
At this point of time, you like to comment?
On examination, patient is conscious, coherent and cooperative, well-oriented to time, place and person, short-statured and moderately nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Blood pressure was 120 by 80 millimeters of mercury, pulse rate 78 beats per minute, respiratory rate 18 cycles per minute, temperature was febrile. On systemic examinations, CVS S1 S2 heard, respiratory system normal vesicular breath sounds, CNS no focal neurological deficit and spine was normal. On ocular examination, head posture, chin elevation was present, facial symmetry is maintained, forehead was normal. Both eyes extraocular movements were restricted in all cases. Coming to ptosis evaluation, right eye, palpebral fissure height was 5 millimeters, margin reflex distance 1 was 0, margin reflex distance 2 was 5, levator function test was 4, Wells phenomenon was absent.
Your language is too specific to the ophthalmology. The audience are too general. Therefore, when you are talking about ptosis evaluation, the palpebral fissure, you mentioned it. Within brackets, you must also mention what is the normal likelihood of a palpebral fissure and many more things for the audience to understand in clarity.
Normal palpebral fissure in a male would be an average of 10 to 11 millimeters and in a female it's up to 9 to 12 millimeters. Margin reflex distance 1 is the distance between the central corneal reflex to upper lid, middle of the upper lid crease. Margin reflex distance 2 is from the lower lid, mid of the lower lid to the central corneal reflex. And a sum of margin reflex distance 1 and 2 gives the palpebral fissure.
It might be prudent just to show on the photograph, Viva, for everyone's clarity. What is MRD1? What is palpebral fissure height? Just show on the photo, maybe with the cursor. If you have a laser.
From the mid of the upper lid margin to the central corneal reflex gives the MRD1 and lower lid margin middle to the central corneal reflex gives MRD2 and the total height is the palpebral fissure height.
Input and center and output action. But here, simply you are measuring the upper lid margin to the top, this and to this. There is nothing reflex. It is a passive measurement. Why it was questioned at any time in your literature?
I don't think so, but what you said is correct. So here we are talking about the
Because the moment marginal reflex, the reflex what you use, youngsters and the physiology think what is the apparent, where is the apparent, what is the center. But this is a passive measurement of distance.
Correct.
This is my layman's question. How far it is tenable in ophthalmic circles of academy, you can put it and make errant, because errant. If it is errant, correct.
Levator function test was 4, Wells phenomenon was absent, fatigue test is negative and ice pack test was negative. Coming to the left eye, palpebral fissure height was 5 millimeters, margin reflex distance 1 was 0, margin reflex distance 2 was 5, levator function test was 4, Wells phenomenon was absent, fatigue test and ice pack test were negative.
Why you see the Wells phenomenon at all? He said it is a bilateral ptosis. Am I right? Yes. Wells, why should you see at all? That's the question. Wells is inability to close the eye, whereas he said disability to open the eye. Am I right, sir? A disability is ptosis of open, whereas Wells is inability to close. Am I right, sir? Neurology. Therefore, why should you see when the curtain is going down, Wells phenomena?
This is
No. When there is ptosis,
Wells phenomena should be ruled known before.
I will come in little into the inside of Wells when you speak it. Depends on it.
As a part of ptosis evaluation, Wells phenomena is very
And then you want to say that ptosis is neurological 3 to 7. Am I right, sir? Up to 7. Now, one word about a Wells phenomenon. Like to have your expertise to be spoken on Wells phenomenon. That will assist and make the comments from the neurologist. After you are
This phenomenon is very important for any ptosis patient because we elicit the Bell's phenomenon. You're correct that the eyelid is already down, but we have a way of eliciting the Bell's phenomenon, standard.
what it is defined is the Bell's
That will be
physiological or pathological.
It's absolutely physiological.
Yeah.
It's a normal
You
phenomenon.
see a physiological reflex, physiological phenomena.
Normally, Bell's phenomenon is a normal phenomenon. But in the cases of yes, sir, it's normal. It's normal
Yes.
thing. One could have that. Phenomenon. But in cases of LMN event difference, we use because in LMN facial basic it is lost because of the.
Now that's why I asked the question. The phenomena is lost or the phenomena is made work because he is not closing the eyes. It is not abnormal.
But in this patient, there is an absence of the complete eye movements also. It's very difficult to test. I think it's not.
We come to it later little. As our discussion said, Bell's phenomena is a physiological age-old phylogenetic reflex to preserve the corneal integrity when you sleep. Because when you sleep, if the cornea doesn't hide, you may injure with your own fingers, and every 1 out of 5 will become blind in the population. To preserve that corneal integrity of transparency, the Bell's phenomena evolved over a million years from that of the crocodile reptiles to that of Homo sapiens erectus bipedus. And the eye rolls when you sleep upwards, inwards or outwards.
Upward and outward.
That is a phenomenon which has not been described in a textbook. It's inside. Upwards is described. Upwards inwards or upwards outwards is not been clarified in the neurological literature for the last 120 years after the Bell's has recognized this. Till now. Therefore, there is no paper on that. That is the physiological. Therefore, why you see when it is closes, it is already addition to the normal phenomena. In seventh nerve palsy, it cannot close, and therefore it automatically normal even without sleep it goes up. Therefore, you are bound to see as a neuro-ophthalmologist Bell's component. But the purpose of it is what, why, how, and that is more important component. Therefore, it is nothing like an opposite Bell's phenomenon. That's wrong. Bell's phenomenon is physiologically present in this. Or opposite. You tell me. You should expect it to be present. Opposite means the eye is not moving at all. That is what is the secondary inference, not related to the primary Bell's but something else.
Eye movements, sir.
Importance of Bell's phenomena is for us surgical decision making. It's very important because if there's no Bell's, the concerns of exposure keratopathy are very
Extraocular movements, monocular movements which are ductions, limitation of subduction, introduction, adduction, abduction, intorsion and extorsion. Binocular movements, limitation of dextroversion, levoversion, dextro elevation, dextro depression, levo elevation, levo depression, elevation and depression. Anterior segment evaluation of right eye. Best corrected visual acuity was 6/12. Eyebrows were normal. Eyelids, severe ptosis was present. Eyelashes, conjunctiva were normal. Cornea size, shape, sheen, surface were normal. Sensations were intact. Sclera was normal. Anterior chamber depth was normal with no abnormal contents. Iris, brown in color with normal crypts and furrows. Pupil, single 3 to 4 millimeters, round and central with direct and consensual reflexes present. Lens was clear. Intraocular pressure was 11 millimeters of mercury. Left eye best corrected visual acuity was 6/12. Eyebrows were normal. Eyelids, severe ptosis. Eyelashes and conjunctiva were normal. Cornea size, shape, sheen, surface were normal. Sensations were intact. Sclera was normal. Anterior chamber was normal with no abnormal contents. Iris, brown in color with normal crypts and furrows. Pupil was single, 3 to 4 millimeters, round and central with direct and consensual reflexes present. Lens was clear. Intraocular pressure was 11 millimeters of mercury.
Yeah, so we are now that we are done with the ocular examination, let us again try to just fill in this data and again try to shortlist the differentials that we mentioned from his history. So you have said that go back to the ptosis examination. So for all the non-ophthalmologists there, whenever we work up a patient with ptosis, the three most important things to look for are margin reflex distance, that is the distance in between the upper eyelid middle point to the central corneal reflex. Second is the levator palpebris superioris action, that is when we ask the patient to look down and then turn towards the roof, what is the excursion of the muscle we look at. And the third is the Bell's phenomenon. So by looking at these three parameters, it will help us again narrow down our differential. So Viva, can this be congenital ptosis?
Upper lip crease was present, so it can't be.
Good. What else? What was the age of onset?
16 years.
So congenital ptosis will be from birth, ever since birth. And you also said that this is gradually progressive. What will be a congenital ptosis? Congenital ptosis is always stationary. They don't progress over time. Okay, so 2 points already have gone against the diagnosis of congenital ptosis. Severe ptosis can be there in congenital ptosis, but as you said, usually the upper lid crease is absent or is very faint because the LPS muscle is weak there. Bell's phenomenon, how is it in congenital ptosis usually? It is present and good, but that is not the case here. So, based on all of these, that is the age of onset is at 16 years. It is gradually progressive. Severe ptosis, poor levator function, but the Bell's is absent, which is going against congenital ptosis. So, this is most likely we are not dealing with the case of congenital ptosis. Can this be a poneurotic ptosis?
Towards our audience,
Yeah.
not to the postcard.
Yeah. So, can we ask them as well?
Yeah.
So, can anyone tell me why this is? Just reiterate the points which are in favor of congenital ptosis and the points not in favor of congenital ptosis. Why are we saying this is possibly not congenital ptosis? Can anyone help Viva and me with just summarizing the points? What are the points in favor of congenital ptosis?
In congenital ptosis, upper lip crease will be
Loud.
In congenital ptosis, upper lip crease will be absent, sir.
That is, so here it is present, so that is against congenital ptosis, okay?
And age of onset is since birth, and here we have it since 16 years of age.
Very good. Second
Also, it
point
is not progressive, it is stationary.
in congenital ptosis.
Congenital ptosis.
And is congenital ptosis majorly at the unilateral or bilateral?
It is mostly bilateral.
No, congenital ptosis 80% are unilateral. Here it is bilateral. Again, might be against. Okay, what else?
Bell's phenomenon is good.
Good. And what are the points in favor? Like what are things which are similar to congenital ptosis in this patient? That it is a severe ptosis with poor LPS action, which is also the case in congenital ptosis. But because the age of onset, the mode of progression, the lid crease height, the Bell's phenomenon, all are going against. So possibly this is not a case of congenital ptosis. Okay, very good. Thank you, Sharon.
Can you elaborate a little on those last two tests? Why you have done it? What is the meaning of that? Reference to the audio.
Okay.
Reference to the common audio.
Yeah, so Viva, you would like to take that?
Fatigue test and ice pack test were done to rule out myasthenia gravis.
But Viva, did you feel this can be myasthenia gravis from history, any indicator?
Just the ptosis and movement restriction.
Ptosis movement restriction is there, but anything in particular, what history does the myasthenia patients give?
Myasthenic patients are usually middle-aged females and they'll have fatigability and variability.
See, fatigability, variability. Okay, so variability, how do you ask a patient about variability?
Does the grouping improve with
Okay. So, myasthenia gravis, variability is a very important. So, like in the history, nowhere we were mentioned about variability. So, variability is the patient will say ki morning when I wake up, my eyelids are absolutely fine. As the day goes through, as I am more stressed, in the evening hours, my lid falls. This is a typical history of variability. So, whenever the history of variability is there, we think about myogenic ptosis or myasthenia ptosis in particular, myasthenia gravis in particular, and there these two tests that she talked about, fatigability and ice pack test, they come positive. Okay, so myasthenia, again, in the myopathic ptosis, the top two diseases that we deal with are chronic progressive external ophthalmoplegia and myasthenia gravis. So this is not myasthenia gravis because there is no history of variability and Viva has done fatigability and ice pack test. There is no improvement is what she says. Okay, that's why this is not myasthenia gravis. So can this be aponeurotic ptosis? Anyone, any of the other ophthalmology resident will like to take this? What are the points in favor and against aponeurotic ptosis? So we have ruled out congenital ptosis, we have ruled out myasthenia gravis. Next is aponeurotic ptosis, which is the most common form of acquired ptosis. So why do I say that this is not aponeurotic ptosis? The reason being aponeurotic ptosis is most commonly in elderly. This is not a 26-year-old gentleman. Aponeurotic ptosis most commonly we see in an elderly gentleman. It is usually bilateral, maybe asymmetric. So from that point of time, as it's a bilateral ptosis, aponeurotic ptosis also needs to be in our differential. But I rule out that differential based on the finding. The major point against is the levator action. Levator action is very good in cases of aponeurotic ptosis because in aponeurotic ptosis the problem is not there in the muscle. The muscle is absolutely healthy. It is just because of senile changes, the aponeurosis of the muscle becomes weakened, dehiscent, stretched out.
It is a ptosis occurring at the age of 16 years. Because of the two tests, can you rule out the variants of congenital myasthenic syndromes which respond to your fatigue test and other things as a presentation of ptosis? Because at the age of 16 years, you can have a congenital myasthenic syndromes which are different from classical myasthenia gravis. Comment on this at this point.
It's very difficult to rule out.
Because the congenital myasthenic syndromes, those tests will not be
there. There may not be have any fatigability won't be there in our patients.
At this point, there are still chances it can be a congenital myasthenic syndrome.
Definitely.
Unlike the myasthenia gravis, which will have the fatigue and ice pack test may be positive.
That when people sparing.
Yeah. People are not.
People sparing extraocular muscle, external ophthalmoplegia ptosis.
No, my question is at this point,
you should consider
most likely myasthenia gravis this is not, but still maybe a news going ahead with a neosegment test might be a way.
But there are other features not major in computation.
Classical myasthenia is good.
Classical myasthenia is ruled out, yeah. And we have ruled out aponeurotic ptosis, no history of trauma, so this is not a traumatic ptosis. So what are we left with, Nima? So this is not a mechanical ptosis also, because there is no mass on the eyelid or any scar pulling on the eyelid. That is also not the case. So this is not a mechanical ptosis, and again it is bilateral. So in all possible, with everything that we just saw, the history and examination, it is a case of chronic progressive external ophthalmoplegia. Is what we feel, and now we need to find out about the other problems that the patient has. Everything we need to fit into one diagnosis. So should we go ahead, Viva? So the external ocular muscles and all the muscles in all the cases are affected. There is bilateral severe ptosis. Did you talk about the fundus finding?
On dilated fundus examination, right eye, media was clear, optic is normal in size, vertically oval, pinkish orange in color, margins were clear and distinct, cup disc ratio was 0.3:1, blood vessels, there was arteriolar narrowing with AV ratio of 1:3. In the macula, there were multiple black, bony, spicule-shaped deposits, retinal pigment epithelial degenerative changes, foveal reflex was dull, background retina showed multiple black, bony, spicule-shaped pigment deposits in the mid-periphery. Left eye media was clear, optic disc normal in size, vertically oval, pinkish in color, margins were clear and distinct. Cup disc ratio was 0.3:1. Arteriolar narrowing was present with AV ratio of 1:3. Macula showed multiple black, bony, spicule-shaped deposits. Retinal pigment epithelial degenerative changes. Foveal reflex was dull. Background retina showed multiple black, bony, spicule-shaped deposits in the mid-periphery.
So we have a fundus here. I don't think this is pink. There is pallor. So there is bilateral disc pallor. There is arteriolar attenuation. There is bony spicule degeneration. So this is a typical clinical picture. This triad that you see here, the disc pallor, disc pallor, arteriolar attenuation, and the bony spicule pigmentation everywhere. This is a typical fundus finding of retinitis pigmentosa. So now our severe ptosis patient who has extraocular muscle motility in all cases also has retinitis pigmentosa. So let us move ahead and see. So this retinitis pigmentosa now explains for the night blindness that we saw in the history. So now we are getting some understanding of the varied history that was there for this particular patient.
The differentiation between retinitis pigmentosa related night blindness and vitamin A preventable night blindness. Is there any clinical clue or nothing, only fundus examination? Number one. Number two, this arterial narrowing denotes here any arterial disease or only simply a background degeneration making it to have a high light reflex making the vascular component? My question. Can you clarify that?
A part of the general degeneration, like whenever there are mitochondrial deletion, it is the oxidative phosphorylation of the tissues is at stake. So anywhere like a RP, retinal pigment epithelium, which is a very high energy demanding tissue, it is not getting the required ATP, and that is causing the degeneration and all these changes that we see. So it is basically a degenerative changes because of absence of ATP in a condition that we are dealing with now.
Phenomena.
Yes, it's a secondary vascular phenomenon.
Beyond certain decibel, living in the airport era where there is things, or in certain of the factories where they use noise and all these things. Or is it really non-noise related eighth nerve involvement noise that makes a lot of difference in the differential analysis?
Occurs like the myopathic ptosis syndrome, it involves hearing loss as well because of the same mechanism of lack of oxidative phosphorylation. So I don't think it is correct. Maybe a young person is in a better position to answer, but it is not noticeable to you.
Cardiac evaluation is normal, but this may be a congenital heart block which might have required a pacemaker. So congenital heart block and deafness, and they are allowed. They are having syndrome, but I don't get anything straight away for ocular condition.
Yeah. My question at this point is required pacemaker at a very young age of 20 years, second decade. This is unusual. It excludes all cardiac problems of acquired nature, except the heart component of it. 2, it can also occur in a long QT interval syndromes with an abnormality in which you don't put a pacemaker, you also put a pacemaker with the defibrillator component of it. You are very sure that it is a pacemaker, but you are not given any amount of data, what type of pacemaker, for what it was done at that point of time as a resident. History is like that.
Probably they would not have that record.
They should check the record when they are presenting it.
These patients, they don't have it. Because nearly 10 years back was done. So
Something. Why? That's very important. It is a syncopal component which is needed. It is a head territory of long QT syndromes. It is a exertional component which makes him to have a syncope. Then he had a complete heart block, which is a primary conducting disturbance which needs a simple pacemaker. Without
I think, this is a congenital definitely, and the ptosis is also there. So whether all these things can correlate.
Any resident of
I don't get any.
cardiology, sir?
I don't get any syndrome which has this combination.
But a congenital complete heart block which necessitates a pacemaker usually occurs associated with congenital heart disease as an Epstein's component. Usually, you will search for it. Therefore, in this pacemaker at 20 years without any symptoms, is nothing to do with the congenital heart disease, but something to do with the extracardiac defect.
Sometimes children born to SID mothers will develop congenital heart block. So whether SID is there in the mother, which might have produced like
or can have congenital block. But this is not cardiac block. It is a tissue-related component.
I think it is pretty clear with everything. This was a very typical. Yeah. So
Now, further dilating what you want for that, what is your final conclusion and what investigation you like?
Yeah. So with the way we have looked into the history and the ocular examination of the ptosis, this can be nothing but CPU, that is chronic progressive external ophthalmoplegia. Usually it starts in young, at around 20 years of age. It is gradually progressive, symmetrically affecting both the eyes, extraocular motility and levator. So it is a ptosis and UA motility limitation what our patient here has. And it is progressive. So that's the name, chronic progressive external ophthalmoplegia. It is not myotonic dystrophy because we were talked about that the other muscles were all fine. There was no history of any dysphagia. There was no history of any other problems like we need to ask the patient about.
As an ophthalmologist,
so standalone, we are not being able to connect all the dots just with any of these diagnoses. So this was the case of Viva.
But in myasthenia gravis, we expect the patient having diplopia, but in this patient, there is no diplopia. I mean, how do you explain it?
So, myasthenia gravis in our practice, we call it the great masquerader. Myasthenia gravis can present with just the lateral rectus deficit, just the abduction deficit. It can also present with a global limitation like this particular patient. So, when it is a global involvement, there won't be any
answered your question. The moment the diplopia is present, CPU goes to the last. And myasthenia and other things come.
Correct.
Therefore, as we were discussing third, and they have presented it that there is no diplopia, we saw symmetrical uniform homogeneous muscular dysfunction is uncharacteristic of myasthenia, which always presents with diplopia and unilateral or bilateral. Therefore, the definition of CPO is itself absence of diplopia in 80%. Because there is in medicine, there is no golden rule. Only the golden rule is there is no golden rule.
Yeah.
Therefore, till 10% of CPO can also have diplopia. And 10%, as Madam said, myasthenia may not have diplopia.
So, but yes, the classical signs were not here. So this was a case of
That's Madam. What if I go back? Why did you want to catch the fight?
She is not supposed to say, because the muscle biopsy part will the audience understand without the.
Do what? Go back. Go back with the forward and the now, for discussion, what is
PO with retinitis pigmentosa along with a cardiac conduction defect. So this is a typical triad what we see in a patient of Kearns-Sayre syndrome. So if like Kearns-Sayre syndrome is like less than 20 years of age of onset, CPO and retinitis pigmentosa. So whenever we see all of these, we think in lines of Kearns-Sayre syndrome. So it is a clinical diagnosis. We don't go ahead with a biopsy, but if we want, we can go ahead with a biopsy from any of the skeletal muscles. The skeletal muscles will show the typical red ragged fibers. Sir, will I ask her to go ahead?
Sir, Madam, I wonder, nowadays, before doing like invasive procedures like muscle biopsy, can you advise like a genetic testing in this patient? Genetic testing also gives the answer. There is no need for invasive procedures.
Yeah, absolutely. We can go ahead. This is the clinical diagnosis. Majority of the patients, you need not do anything. But if you just want to understand the lineage and the chances of affection, then genetic testing is the way ahead. We hardly
I do not agree to that component of genetic test at the point of time for the reason genetic test is always a complex procedure of highest amount of
very costly
efficiency at a reduced cost. And it has a deficiency of interpretation because it opens the Pandora's box of hundreds of conditions of life. Number one. Number two, whereas you can get a small biopsy in which confirms what is the pathology, which makes a distinctive component of a lower spectrum of protein, multiple Hubli junction kakuta, it is our Gannavaram junction now, if you take a Number two, is there any non-invasive test which can pick up the diagnosis other than genetic? In these cases, therefore, your diagnosis is Kearns-Sayre, or you pronounce that's a different thing. And that it is a myopathic disorder primarily, but it is a different myopathy than neural myopathies of nature. Can you little elaborate on that? Because you are touching on the point of oxidative component of energy. What made you to think oxidative component of energy? And this is a myopathy of that nature, mitochondria.
Yeah, so basically the telltale signs in all the organs which require high oxygen are affected in this particular patient. The triad that we talked about, CPO, retinitis pigmentosa, less than 20 years of onset, that was there.
Wonderful. At this point I got a question. The same amount of energy is needed by the mitochondria with a somatic muscle. The same mitochondria is needed for the energy of eye muscles. Why should that eye muscle will be first affected without somatic involvement and somatic muscle is being spared in these things? That's my question for the what is called dilatation of the subject.
Yeah, I don't think, sir, we have an answer to that. It will be exactly why the oxidative phosphorylation is more affected in the levator and the extraocular muscles vis-a-vis the skeletal muscles.
Yeah. Mitochondria does the same work irrespective of any cell in the body. They are responsible for powerhouses of the body which generate. Therefore, the requirement of the power, is it a three-phase wiring to phase wiring 520 volts or 450 volts or 275 volts depends. But the tissue which does more work. Therefore, as a component of it, normal muscles hardly walk 24 hours a day. Hardly, unless you voluntarily make them walk. But ocular muscles and the cardiac muscle do work whether you like it or not. Otherwise, your life becomes miserable. That's why the ocular muscles are endowed with 3 times to 4 times the density of mitochondria in the ribbon muscles. Therefore, the density of mitochondria and somatic muscle, if it is 1 per 1 fiber, for the sake of it, it is not true. The same fiber will have 25 to 30 mitochondria in ribbon muscles. That's why, therefore, when the mitochondrial dysfunction occurs, the somatic muscles suffer little. In the myasthenia, when he exerts only, he comes. Myasthenia is not mitochondrial. Even mitochondrial disease of the somatic muscle exerts. Whereas, they exert without your knowledge involuntarily. That's why all mitochondrial diseases first manifest in the ribbon muscles of the eyeball, and the next, the involuntary muscle of your heart to some extent, whether it is quadrates or whether it is myotonia or whether it is chronic progressive ophthalmoplegia, mitochondrial psychopathies and so on. Therefore, the same mitochondria, but the energy requirement is 10 times more, 10 to the power of 2 is in a ribbon muscle. In somatic muscle, it is just 10 joules, that is 100 to 1000 joules. That makes them to suffer.
Correct. So that is the reason, like all
cycle is same. Citric acid cycle is same. Glycolytic cycle is same. Energy release is same. But energy expenditure is very huge in ribbon muscles.
yeah. So all the high like in this particular patient, all the high energy requiring organs are affected, like pancreas, heart, cochlea. I think that is but still we don't know till late in the disease in this cancer.
High energy requirement is not cell dependent, it is a functional dependent, which dictates the quantum of genetic quantitative production of mitochondria in that cell. The cell rise in the pancreatic tissue. The pancreas needs a huge amount of mitochondria, particularly endocrine component of cells, beta cells. The same way, the cochlear component of endothelial cells also need, because they do a lot of work, whether you rise or see or tongue or anything. Yeah, but in this coefficient of mitochondrial energy, the first goes to the ribbon muscles, the last somatic, in between there's 8 now, and then pancreas, and then many more. In that.
Should she go ahead?
Yes.
Patient was advised muscle biopsy for further evaluation. Patient underwent muscle biopsy at a diagnostic center elsewhere, and it showed presence of black red fibers seen in trichrome stained skeletal muscle biopsy.
Comments from the pathology? Faculty or assistant?
Sir, this particular slide shows the skeletal muscle fibers, and the red color indicates that it is an collagen which has been present in that, and this shows that there is an defect with the mitochondrial aspect is seen.
These mitochondrial cytopathies can be picked up so fast in the somatic muscle or so fast in the ocular muscles. That's what my question is. Caldemasel rarely have that mitochondria. You don't get it. But when present situations, they are the academic investigations. Because if they are not done, this particular ocular biopsy and electron component of electron microscopy, they would not have known what is the density of mitochondria, how the mitochondria degenerated, and what is the specific states which a particular component, the energy component is abnormal, and all these things. And then genomic component comes, which makes the functionality expressed with the genomic activity. Therefore, there is nothing like I advise, I insist that the Institute of Premier Sciences of LV Prasad, which is responsible for an ophthalmic demo of the greatest institute in India, should not refrain from biopsies up to the level of electron microscopy and functional staining of the mitochondria for you to pave way for the future of understanding and newer therapeutic horizons in mitochondrial cytopathies.
We do for
I'm not talking. You told that you are from a big institute. Therefore, my appeal is that you don't stop there, go beyond. Then only the life becomes searchlight, searching the future. Otherwise, it becomes a fuse light.
Biopsy. Nowadays, we are doing first genetic testing. So nowadays, in literature also the guidelines also say first do genetic testing, then go for.
Then science, the genetic test doesn't confirm it because there are 100 or not genes. What
Yes, sir. That too, it can be there.
Okay, we come to the genetic component. Come on, in the good old days, when I was student of MD, all spinocerebellar ataxias used by names, Mary's, Campbell's, Netherlands, or something like that. Now, they have been genetically coded to know that is S122 single morphism 1 by 4 cube, P247 is abnormal. It makes sense for the research people, but it doesn't make sense for the therapeutic patient or a treating doctor.
It makes difference. Let me tell you, that the genetics are entirely epigenetic.
Yeah, therefore, here the blood cell syndrome itself, there is a huge number of markers. If you want to dilate what you experience for the blood cells in your practice of faster on the
like what this patient had, the entire gamut of problems that is absolutely very unique and rare. So what we see is the typical triad, but the other things like the conduction defect, ptosis, extraocular motility limitation, retinitis pigmentosa. This is what we see. But the pancreatitis, hearing loss, everything in this patient, that was something.
Put it as a resident,
Yes.
but not otherwise. But because it is a rarity, but something like vitamin A deficiency, it is difficult to make with differential diagnosis and all these things and make it with a nature. But this is very easy. As Madam told, CPE, complete progress of ophthalmology, retinitis pigmentosa, only 4 or 5. Then the other one is darkness and over. Darkness is over. What you do, nothing. But this is an important thing for make us to progress in a mitochondrial abnormalities in India. Because cancers in India, predations is not similar to cancers in Caucasians and other things. Therefore, we should catch it and make it and plow it.
The other important clinical point which we all should remember, more so for ophthalmology, is that whenever you suspect a patient to have CPO in your clinic, you need to rule out, you need to have a dilated fundus evaluation, need to rule out retinitis pigmentosa, and we also do ECG in all such cases to rule out a cardiac conduction defect. So these are the two things, all cases of CPO we need to rule out when the patient presents to us. So this case should teach each one of us, and that is what we should take back.
The first researcher granted
India, who is professor and author of
therefore.
At that time, what she did was, what she was doing is, take mice and separate the birth after birth from the mother. And they were analyzed the mitochondria. There's definitely a lot of difference.
No,
With the other
exactly.
one,
Can I little elaborate on that? That is, an offspring separated after birth from the mother, the stress itself will cause mitochondrial functional abnormality, and also it causes mitochondrial DNA expression component. For that, 1 crore scholarship was given.
3 years. It took more than 3 years. But what
And
happened?
it can be prevented by anti-stress component of simple vitamins. In the
You're aware. Vote. That's what it is. It just the
stem cell.
once they have given and still they separated. Also they did. And for this, not our 3 crores has gone for investigation. The beautiful thing is, the best thing that happened to her is that Infosys has given, on every year they give, last week they give that in groups. This particular thing, she was given about 70 lakhs or something. She got that for a person. See, so simple things.
There needs to be a clear, cardiac anomaly. That's fine. Our anesthetist can take care of that part. But we need to have a clear discussion with the parents about the risk of exposure keratopathy. So traditionally, that all of us have been taught and what is the treatment of choice for these patients are the lid props or the crutch glasses that
Crutch
we give.
glasses is the best option for this.
I won't say it's the best option, but that is the safer option because
We don't know what are the glasses is speaking. It is Greek and black, little blur explain.
There is a spectacle called crutch spectacle, sir, which elevates the lids. When the patient wants spectacles.
Therefore, there is innate mechanism in the spectacles which elevates to see. When you remove it, it closes. Therefore, you prevent the exposure.
Yes.
Correct. So it's like a crutch glasses. It is just a prop attached on the upper rim of your spectacle. It can be either a spring or a plate. So that is attached. It is a customized thing that our opticians make.
In the night they can remove it and have a happy.
Yes, during the daytime they're taught to put their eyelid over the crutch so that they can manage their day-to-day activity.
Rather than surgical appointment.
Correct. But what we see is many of these patients come back to us because at the point where the crutches touch their eyelid, they have developed ulcers, they have a lot of pain. So there we have to, we have a series where we have done surgery for this group of myopathic patients where the Bell's was absent. But in those cases, what is important is we need to have a clear conversation with the parents about the risk of exposure keratopathy, the need for copious lubrication eye drop in the post-op period, and the choice of surgery. The choice of surgery is not levator resection in these cases, but tarsofrontal sling. Basically, there are 2 types of ptosis surgery. We prefer the tarsofrontal sling surgery.
You want to explore and make a transplant of the muscle which acts.
No. We are just using a exogenous silicone tube in the eyelid. So basically, with the forehead acting, the forehead pulls the eyelid up. So this silicone tube has a elastic potential.
Our blinders are curtain, it pulls like that.
Yes. But what is again important, the outcome in these patients, we don't want them to look normal. We want just their visual axis to be cleared. So we do this ptosis surgery with predetermined undercorrection. So for all the residents, what your examiner wants during our examination is this term, that we do ptosis surgery, tarsofrontal sling, silicone with a predetermined undercorrection. We don't do the normal ptosis surgery where we want them to be cosmetically normal. No.
Lastly, as you said, counseling and all these things. Whom you counsel, the patient or the other
parents? So this is a 26-year-old. The parents and the patient himself, he is a major, so we can counsel him as well.
There are other persons, anything you like to say? Any newer therapy? Because everything is now implantation and genomic medicine, and so on.
Not that. What I would like to tell you is the New England Journal of Medicine publishes reports of mass in hospital. They said for 2 months in advance publish it, and they asked across the world to send the discussions and give final discussions. The 9 people were correct a few months ago. Correct diagnosis was given by only 9. Among so many we have submitted to New England Journal of Medicine. Among the 9, my friend is one which got your 9th hepatitis, right? Liver aspiration is the big. CPC, he forgot about it. He doesn't remember the CPC, they send in advance, everybody can give that, and they will review. Only 8 to 9 people were correct. One is among them being diagnosed. Aspiration pneumonia, something aspiration pneumonia. So we are these meticulous diseases. I don't think anybody the way he catches. So he may be a little aggressive.
Hearing loss, it is also progressing. And actually, this is a congenital and short stage is also present.
Yes.
And classical hearing syndrome. But how long the age we can expect the person will live?
They have difficulty in living because
this is
able to function by replacement. These are normal muscles to move up and they are able to eat except eating get diabetes. But some involvement other than the small muscles occurs. This is another happen. Therefore, it is progressive. That's why age is important. Before 20. After 26 years, there is nothing to progress. It is already progressed beyond redemption, except giving a palliative, social, and
yes. And most of these patients do not survive beyond 4th decade.
Yeah.
Because it is multi-systemic disease, it involves all organs progressively.
The first thing to kill them is heart. But they buy another medication. And then respiratory muscles of diaphragm. The moment it starts in water, then whereas somatic muscles, the mitochondrial DNA disease.
Yes, sir.
Unlike the other. Therefore, it is an energy-related component, the density of the matter. There is no living cells without mitochondria, and this is called non-living cells. Therefore, all human living cells are mitochondria. All will suffer at the end.